thinking of the fear I've had so long. When somebody hears, listen to the fear that's gone, strangled by the wishes of Peter, hoping for the arms of Mater. Get to me the sooner of later. Holding back the years, chance for me to escape from all I've known. Holding back the tears, 'cause nothing here has grown. I've wasted all my tears, wasted all those years, and nothing had the chance to be good, and nothing ever could. Yeah, I'll keep holding on. I'll keep holding on. I'll keep holding on. I'll keep holding on. So tight. Wasted all my tears, wasted all those years, and nothing had the chance to be good, 'cause nothing ever could. Oh yeah, oh yeah. I'll keep holding on. I'll keep holding on. I'll keep holding on. I'll keep holding on. Holding, holding, holding on. Yeah, 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 yeah. That's all I have today. It's all I have to say. All I have today. All I have to say. When you were here before, can look in the eye. You're just like an angel. Your skin makes me cry. You float like a feather in a beautiful world. I wish I was special. You're so very special. But I'm a creep, and I'm a widow. What the hell am I doing here? I don't belong here. I don't care if it hurts. I wanna have control. I want a perfect body. I want a perfect soul. you notice when I'm not around? You're so very special. I wish I was special, but I'm a creep. I'm a weirdo. What the hell am I doing here? I don't belong here. Whatever makes you happy, whatever you want. You're so very special. I wish I was special, but I'm a creep. I'm a weirdo. What the hell am I doing here? I don't belong here. I don't belong here. Give me time to realize my crime. Let me love and steal. I had danced inside your eyes. How can I be real? Do you really want to hurt me? Do you really want to make me cry? Precious kisses worth and burn me. Lovers never ask you why. In my heart a fighter's burning. Choose my color, finest star. Precious people always tell me there's a step too far. Do you really want to hurt me? Do you really want to make me cry? Do you really want to hurt Ladies and gentlemen, this morning's program is about to start. Please take your seats and mute your phones. To introduce our first plenary speaker, please welcome Ambassador Deborah Birx. Ambassador at Large Deborah L. Birx is the coordinator of the United States government activities to combat HIV and AIDS, and U.S. Special Representative for Global Health Diplomacy. Her 3-decade-long career has focused on HIV and AIDS immunology, vaccine research, and global health. As the U.S. Global AIDS Coordinator, Ambassador Birx oversees the implementation of the U.S. President's Emergency Plan for AIDS Relief, PEPFAR, and all U.S. government engagement with the Global Fund to fight AIDS, tuberculosis, and malaria.
Thank you. Thank you. Good morning. It is really my deep pleasure to introduce a colleague who has been with the fight against HIV/AIDS and translating basic science and clinical science to help others for decades. Yves Levy, an MD and PhD, and now Chief Executive Officer and Chairman of INSERM, the French National Institute of Health and Medical Research, also the Director of the French National Alliance of Life Sciences and Health, and Professor of Clinical Immunology, who has been exploring the role of the immune system in combating infectious disease for helping others to conquer their own diseases. He has been extraordinary in his leadership in vaccine development, new and interesting therapeutics, and continues to really lead teams that will bring us to the end and have a vaccine and cure for all of us. Yves, it's a real pleasure to introduce you, and thank you for your plenary on harnessing the immune system to prevent and control HIV infection. Yves.
Good morning, everybody. Your Excellence, thank you for this kind introduction. First, I'd like to thank the organizers and the chairs of this meeting for this invitation. It's a real privilege to be here today and with you. I tried to discuss how to harness the immune system to better control HIV infection. I think it's fair to recognize that we have not yet achieve the right strategies to fully utilize the potential of the immune responses to prevent and control HIV infection. In a natural infection, the immune system is clearly falling short. The immune responses are not able to control HIV in the large majority of patients. HIV causes also major abnormalities in the immune system, and we know that once an infection is established, HIV cannot be eradicated despite restoration of the immune system after years of treatment. This slide outlines key components of the immune system and how they interact with the HIV during an infection. Although HIV-specific CD8 T cells are on your right, these responses are a dominant player of the immune control of HIV. There are multiple additional factors that contribute to this outcome. These relate to the upregulation of immunoregulatory receptors on dendritic cells on the top of this slide, and their role in the generation of effector cells activation of CD4 T cells, the generation of effective antibodies, neutralizing and non-neutralizing antibodies, and also the role of innate immunity and NK cells. In this presentation, I'll try to highlight new insights into the mechanism of immunology and immunogenicity because they provide new tools to reprogram the immune system and improve vaccination and other immune-based strategies to fight HIV. In the past 25 years, therapeutic vaccines have been tested to enhance these pre-existing HIV cellular responses. And as outlined in this slide, in general, these vaccines are capable of stimulating pre-existing HIV-specific cellular responses. In some trials, these responses were associated with a partial control of viral rebound following treatment interruption, but no one prevented virus rebound. While clinical results were quite disappointing despite stimulation of cellular responses are not clear, it's possible that these immune responses don't target HIV cell reservoir, or that elicited responses don't recognize relevant epitopes of HIV emerging from these reservoirs, or that these responses keep markers of energy or don't access to privileged sites. Or finally, we may need something else than vaccination or in combination with vaccination. If we are to achieve immune responses that can effectively control HIV infection, there are a number of key issues to be considered. I'd like to discuss some of them, and among them, one of the main barriers is the establishment of HIV reservoir. 25 years ago, J.P. Pantaleo showed that HIV infection is active in lymphoid tissues during the chronic stage of infection. The virus is concentrated in lymph nodes, and the white dots on your left in germinal centers represent the virus particles trapped at the surface of follicular dendritic cells. More recently, this group has shown that lymph node T follicular helper cells, a subpopulation of CD4 T cells defined by the expression of CXCR5 and PD-1 molecules, serve as the major CD4 T cell compartment for HIV replication in naive or hard-treated patients. These TFH cells are localized almost exclusively within germinal centers, as shown on your right. These sites are characterized by T-cell activation, massive cytokine production, and thus may serve as a privileged anatomic compartment for active or residual virus replication. Several studies have shown that cytotoxic CD8 T cells have a limited access to germinal centers, and antiretroviral drug penetration might be reduced in lymphoid tissue. Therefore, this may represent a major barrier for functional HIV cure and virus eradication. The majority of lymphocytes are localized within lymphoid organs. Indeed, the blood contains only 2% of total lymphocytes. Mosef Ben-Kiran teams identified recently in the blood a population of latently infected CD4 cells expressing the CD32A marker. This marker, which is a low affinity Fc receptor for IgG, is usually not expressed by lymphoid cells. As shown on your left side, for several patients studied, these cells contain the highest level of proviral DNA. On average, these cells represent around 60% of the HIV reservoir in the blood. The CD32A appears to be a marker for CD4 T cells that harbor replication-competent proviruses. This very exciting finding raises several questions, and among them, the significance of this expression and the functional role of this marker. Anyway, identification and taking the advantage of the identification of the phenotype of TFH or CD32A cells, this slide shows different approaches that could be considered for targeting these cells. For example, we could design antibodies targeting PD-1 or CD32A molecules, or bispecific antibodies that can target also HIV antigens. These antibodies could also deliver toxic agents. It's likely that beyond this effect, the activation of cellular responses will also be essential. The use of PD-1 antibodies, for example, offers the possibility to test two potential concepts of immunization. First, the reduction of HIV cell reservoir by a direct killing, and the recovery of exhausted CD8 T cell function as developed in the cancer field. Several trials evaluating anti-PD-1 are ongoing, and one of the key issues is, of course, to demonstrate their safety. Turning now to the second of the issues that we need to consider for achieving improved immune control in HIV infection, how to identify markers associated with the control of HIV replication. To help address this question, as others, we hypothesized that the comparison of elite controllers and chronically HIV-treated patients or patients receiving therapeutic immunization might be useful. This heat map shows you that compared to heart-treated individuals, elite controllers show a down-regulation of several inflammatory genes such as TLR, chemokine receptors, and NK signaling pathways. More precise comparison shows that elite controllers have an enhanced T-cell-based immune response in blue on your left, contrasting with in red a decrease of genes involved in the regulation of inflammation, innate immunity signaling, and also a decrease in CD32A expression. These results suggest that a robust immune response combined with reduced or controlled inflammation and CD32A expression characterize these elite controllers. So what happened in therapeutic vaccination? We have previously reported the results of a therapeutic vaccine trial called DALIA. In this non-controlled study, heart-treated patients were vaccinated with autologous dendritic cells prepared ex vivo and pulsed with the HIV peptides. Patients received 4 vaccinations before stopping heart for 6 months. The magnitude of the viral rebound differed between patients. In blue, the set point was 1 log below the other group in red. In this study, we also analyzed the changes in gene expression throughout the study and during the vaccination. This slide shows in each cartoon inflammatory modules grouping functionally related genes. Results show that a down modulation of inflammatory gene expression in the blood after the first vaccination, which returns to baseline level after the 4th vaccination and before treatment interruption. In contrast, modules of T-cell activation related gene expression behave in an opposite way, increasing after the first vaccination, followed by a down modulation. Usually, evaluation of immune intervention relies on separate set of analyses based solely on immune defenses or specific pathways. This may preclude the discovery of novel or previously unrecognized markers of immune control of HIV. This slide shows in these patients in this trial integration of genomic gene expression in the bottom, cellular responses on your right, both analyzed before treatment interruption, and virological parameters post-treatment interruption on the top of this heat map. Taken together, results show that inflammatory gene expression in blue contrasts with T-cell activation gene expression in red. And globally, patients with lower inflammatory responses during the vaccination experienced a better cellular response to the vaccine and lower viral rebound. It is interesting to note that the same modules and profiles of inflammatory gene expression were also reported in other vaccines, such as the flu or pneumococcal vaccines, for example, in this trial. It is in these settings also the level of whole blood inflammation predicts the magnitude of adaptive immune responses in vaccinees. In conclusion, what can we draw from these vaccine trials? Inflammation is necessary to establish vaccine-induced immune responses, but needs to be controlled. These data indicate that the factors and mechanisms that allow the generation of an effective immune response are not always perfectly known, and that for the vast majority of the vaccines currently on the market or in development, we don't always know how they work, what precisely they work, when they work. Delineating how these vaccines may mobilize an integrated immune response is crucial. I'd like to show you examples how advances in technologies such as in vivo imaging in mice and non-human primates may help to dissect vaccine responses. As shown on your right, for example, after ID injection of an MVA vaccine, it's a pox virus used in clinic, coding for a fluorescent protein here, we can track vaccine antigen production in dermal cells in live non-human primates. These technologies allowed in-depth characterization of molecular and cellular changes at the site of vaccination in draining lymph nodes and in the blood. This slide summarizes a large set of data generated in mice. Tools were developed to visualize immune responses in live mice in real time and at a single cell level. The slide shows on the top that MVA vaccination induces within minutes inflammation and macrophages in the lymph node and a burst of inflammatory response with cytokine and chemokines. As shown in the movie here, this resulted in cellular recruitment to draining lymph nodes in red of an influx of innate cells, mobilization of T cells, and generation of robust MVA-specific responses. Interestingly, manipulated mice which are not capable to mount an inflammatory response, knockout for IL-1, for example, did not develop these vaccine-specific T cells. In non-human primates, and this slide shows response to the MVA in non-human primates, and this slide is complex because the response to the MVA is complex. This slide shows integration and interaction between cells, proteins, and gene expression at the site of injection in the skin, in the middle, draining lymph node in the top, and in the blood, and also the dynamics of these responses from hours to days after injection. Lanes indicate significant correlation between each factor. To go quickly, these pathways are complex, but the first analysis highlights the key implication of TNF-alpha, GM-CSF, and granulocytes in the initial response to the MVA, and then a systemic inflammatory response that peaks 1 day after injection and then progressively replaced by adaptive immune response in the blood. Altogether, in conclusion, this data highlights the importance of the orchestration of the inflammation and its mechanism which it promotes the specific adaptive immune response, but also that determining correlates of virus control should be coupled with the understanding of the mechanism of action of vaccine. This also raised the question, how are we translating knowledge on immunology to the development of new vaccine concepts? I would like to show this quote from Ralph Steinman, which paved the way of modern vaccinology, to shift from empirical design of vaccines to vaccine based on recent knowledge in immunology and integrated approach to design concepts in order to reprogram the immune system. I had the privilege and opportunity to discuss this and how to develop new strategies with Ralph and other colleagues, Jacques Banchereau, Carolina Paluca, and Roger Legrand in 2008, almost 10 years now. And you can see here that for Jacques Banchereau, modern immunology was molecular cooking, is to traditional cooking, hopefully more tasty. So one way to enhance the effectiveness of vaccination and to deliver modulatory signal to the immune system is to target vaccine antigens directly at dendritic cells. This largely relies on the functional plasticity of these key professional antigen-presenting cells. Several dendritic cell receptors to be targeted have been selected to boost cellular or humoral immune responses. This involves engineering monoclonal antibodies, targeting receptors on dendritic cells, such as CD40, for example, DCIR, langerine. And for example, these antibodies are fused to specific HIV antigens, such as T-cell epitopes or ENV constructs. A series of seminal observations were made by Michel Nussensweg and Ralph Steinman, showing the efficiency of this approach in animal models leading to antigen presentation and enhancement of T and B cell responses. Several groups, including our group, have generated a large set of preclinical data showing that DC targeting vaccines, either alone or combined with recombinant vectors, elicit strong and robust T and B cell specific responses. I would like to show you recent data generated by Li Shan-Su team in collaboration with the Vaccine Research Institute, using immunocompromised mice reconstituted with the human immune system and infected with HIV. On the top left, this cartoon shows the peak of plasma viral load after infection and the control of HIV after introducing ART. The mice were injected twice with an adjuvant alone or the vaccine targeting T-cell epitope to CD40 receptor on dendritic cells, or PBS as the control. After treatment interruption, a rebound was noted in all mice with a slight delay in vaccinated mice. On your right, you can see that the vaccination elicited a strong, on the top, CD4 response and CD8 response at the bottom, HIV-specific responses producing IL-2 and TNF. Globally, post-ATI, one log difference in plasma viral load was noted in the vaccine group as compared to the other groups. These encouraging results need to be confirmed, but provide a model for testing different combinations of vaccine and other immune interventions. That brings me to the final issue that we need to consider when improving immune control of HIV replication. How to improve immune responses by combining these interventions. In this setting, this study from Dan Baruch's group showed nicely that the combination of therapeutic vaccination with an adeno-26 and MVA SIV vectors, two vaccines combined, and an agonist TLR7 was more efficient than either component alone in controlling SIV replication. As shown in the right, the combination resulted in a significant reduction up to 1.7 log and delay in SIV rebound following ART interruption as compared to control. TLR7 triggering is known to activate dendritic cells and lymphocytes and to lead to innate immune activation. Difficult to say in this study whether the beneficial effect of the TLR7 agonist reflected its potential role as a vaccine adjuvant, a latency reversing agent, or both. Development of neutralizing antibodies and observations concerning their antiviral efficacy in controlling viremia is one of the recent major advances in the field. This slide shows two of several recent studies in ART-naive individuals. On the left, a single infusion of one antibody directed against the CD4 binding site of ENV is able to transiently reduce viremia. On the right, one infusion of the 10-1074 antibody, which targets another site of ENV, led also to a rapid decline of viremia. For both antibodies, this effect was transient, with a mean reduction in viremia around up to 1.5 log. It's unlikely that treatment with a single antibody will be sufficient to control HIV in the long term. Experimental data show that combination of different neutralizing antibodies targeting different sites of HANV are more effective to suppress HIV. One question for further development of these antibodies is how to optimize this effect. The humanized mice model is once again an easily accessible model to treat different combinations, to test different combinations of neutralizing antibodies and other immune interventions. This slide shows interesting data, although preliminary, generated by Jim DiSanto and Hugo Mouquet at the Pasteur Institute and INSERM. In this study, all mice were HIV infected, then treated with antiviral drugs, and then received either one boost of the MVA vaccine or one infusion of the 1074 antibody I just showed you the data in human, of both strategies combined. ART was stopped, and viral load and immune responses to HIV were evaluated 40 days after stopping ART. Results showed that up to 35% of mice in the combined group did not experience any viral rebound as compared to 10% of mice receiving the neutralizing antibody or no mice in the vaccine group. Interestingly, the combination strategy elicited an increase in memory B cells, anti-GP140 IgG responses, as well as HIV-specific T-cell responses in a higher proportion of mice as compared to the single intervention group. The rationale behind this experiment and for further clinical studies is that beyond the neutralizing effect, these antibodies are likely eliciting adaptive cellular immunity, a so-called vaccine-like effect, whereby the antibodies bind to the target cells, which is then flagged for killing by the host immune system boosted by the vaccine. In summary, we have now powerful new tools to evaluate immune responses and reveal the rules of immunogenicity. We should use this to our full advantage to guide optimization of vaccine design. Evaluation of immune interventions need global, unbiased evaluation of interconnected immunological programs, including mechanism of action of vaccines. We need to consider new combinations, vaccine and other immune-based interventions to best utilize the different components of the immune system and reprogram them in such a way that they provide the best chance to control and eventually eliminate HIV. Let me end with this slide from my friend and colleague J.P. Pantaleo. Coming back to the history of therapeutic advances in the field, we have learned step by step that antiviral combinations improved the antiviral efficacy of drugs. Regarding immune interventions, studies showed that single interventions are capable to control only transiently viral replication. Combinations of BNAbs, for example, improves this control. Development of a large armamentarium of immunological interventions should allow combinations of strategies that hopefully will improve the control of HIV replication. However, these strategies are no longer based on an empirical approach, but rely on recent knowledge in HIV physiopathology, better identification of HIV reservoir, and advances in technology. I would like to thank several colleagues and very good friends who shared with me slides, data, discussions, and advices. Without them, I would not be able to present today. All colleagues from the Vaccine Research Institutes, colleagues from the Beyrer Institute in Dallas, very close to us and for this collaboration, the NRS cohort of elite controllers. I have mentioned also several times the contribution of my colleague J.P. Pantaleo, who is also the co-chair of the EVA consortium, European-funded consortium. A special acknowledgement to Mireille Sanliv from the VRI and Esther Kuipers from IAV and EVA for their help in the preparation of this talk, and all the funders and institutions that supported this work. Thank you for your attention.
To introduce our second speaker, please welcome Professor Chris Beyrer. Chris Beyrer is the Desmond M. Tutu Professor of Public Health and Human Rights at the Johns Hopkins Bloomberg School of Public Health in Baltimore, Maryland. He is a professor of epidemiology, international health, behavior and society, and nursing. He serves as director of Johns Hopkins Training Program in HIV, epidemiology, and prevention science, and as founding director of the Center for Public Health and Human Rights. He is the associate director of the Johns Hopkins Center for AIDS Research, CFAR, and of the university's Center for Global Health.
Hi, everybody. Good morning. It's my distinct pleasure this morning to introduce Dr. Wafa Al-Sadr, who's going to give a plenary on persons living with HIV, the top priority for programs. Wafa is an amazing leader in our field. She's university professor of epidemiology and medicine and the Mathilde Krim Amphar Professor of Global Health at Columbia's Mailman School of Public Health and the College of Physicians and Surgeons. Through ICAP, the program she founded about 10 years ago now at Columbia University, she's been instrumental in developing large-scale programs in sub-Saharan Africa and Asia that integrate research, education, training, and practice. ICAP works closely with the U.S. government agencies, international organizations, academic institutions, the private sector, and community-based organizations in the pursuit of responsive, inclusive, sustainable, and innovative approaches to addressing global health threats and achieving public health impact. ICAP supports the training, education, and mentorship of a variety of healthcare professionals with a special focus on the nursing workforce. Dr. Al-Sadr's research interests are diverse, a rather amazing portfolio that includes research on prevention, treatment of HIV, tuberculosis, non-communicable diseases, and maternal child health, among others. She received her medical degree from Cairo University in Egypt, her native country, a master's degree in public health from Columbia, a master's in public administration from Harvard, and she was named a MacArthur Fellow in 2008 and is a member of the Institute of Medicine of the National Academies. Ladies and gentlemen, Wafa Al-Sadr.
Well, thank you very much, Chris, and good morning, everyone. It's a great pleasure to be here today and to have the opportunity to address you on this very important topic, persons living with HIV, top priority for programs. I trust and suspect that most of you in this room are convinced that people living with HIV must be top priority for programs, but nonetheless, I'll try to make that argument this morning. So here's an outline of my presentation. First, I'll briefly celebrate, all of us can celebrate the progress towards controlling the HIV epidemic by showing you some of the data that were released just recently from UNAIDS. Then I'll move on to discuss some of the challenges ahead to achieve epidemic control, focus on differentiated service delivery, DSD, which has been posited as a pathway towards achievement of epidemic control, and lastly end with a way forward and some suggestions and conclusions. So as all of you are aware, the scale-up of treatment has been remarkable. And it was recently announced a few days ago that 19.5 million people around the world who are living with HIV have accessed HIV treatment. This is particularly impressive when you note on this figure that the majority of these individuals come from some of the poorest countries and least resource countries in the world. Now, the scale-up of treatment has led to a remarkable decline in AIDS-related deaths. However, it's important to still acknowledge that more than 1 million people are still dying of HIV per year, a number that's completely unacceptable. Now, the decrease in HIV-related death has led to a rebound or regaining in life expectancy for select countries in sub-Saharan Africa. As you'll notice in this figure, since the 1960s, in these countries that have been heavily impacted by the HIV epidemic, there's been a rise in life expectancy. However, tragically, in the mid-1980s and 1990s, remarkable loss in years of life However, with the scale-up of treatment, we're beginning to see reversal and regaining of those lives lost in terms of life expectancy. It's also important to note the decline in the disability-adjusted life years. And again, you'll notice in various regions in sub-Saharan Africa and in green here in sub-Saharan Africa overall, that again in the mid-1980s, 1990s, and then you can see the increase in DALYs, but nonetheless with the expansion of treatment, again, a decrease in DALYs that are related to HIV. And this is particularly dramatic for Southern Africa, where the HIV epidemic is most severe. And lastly, and of course related to the scale-up of treatment, has been the drop in new HIV infections. Although nonetheless, this is due to expansion of treatment, obviously, but also importantly due to the scale-up of other HIV prevention, primary HIV prevention interventions. Nonetheless, again, we still have about 1.8 million new infections in the past year. So all of these are remarkable successes that indeed we must celebrate that have been achieved largely by people in this room and people who are working in the field addressing the epidemic. Yet there are challenges that we are all facing as a global community that's interested in ending the epidemic. And some of those challenges I divide into these three areas. How do we achieve coverage? How do we achieve quality of programs? And lastly, how do we achieve efficiencies? So coverage and quality are dependent on the HIV treatment continuum. And most of you are aware of this, but it starts with focusing on the population of interest, whether that be a general population, key population groups, or priority populations. And the goal is to identify all individuals who are unknowingly, either they are aware or unaware of their HIV infection, to identify, diagnose such individuals, promptly initiate antiretroviral treatment, retain, counsel, monitor, and support them on treatment so that we can achieve, and they can achieve, suppressed or undetectable viral load that is durable. This requires coverage because obviously this across the board, you have to reach all the people who need the services, but also requires the quality, high quality, and retention in this treatment cascade. So first, let's talk about coverage and what's ahead of us. The UNAIDS indicates in its report that we're on track as a global community to reach the 30 million people accessing treatment. And you can look at the trajectory of number living with HIV on ART now. And indeed, when you look at the target for 2020, it looks quite promising. But when you look at the coverage gap, it is daunting. And we have to figure out ways in which we can reach new populations, reach more of the populations we're reaching now, in order to achieve 33 million people living with HIV who are expected to be accessing ART by 2030. Currently, we're up to 19.5 million. Currently, we need to reach 10 more million individuals with treatment, and then by 2030, add an additional 3.3 million people. So that by itself is quite a challenge. Now, what about the challenge of quality? And I'll spend some time on the issue of quality of programs, because it is fundamental to demonstrating the impact of treatment. Now, the 1990 targets are an important targets for all of us to demonstrate coverage as well as quality. Obviously, for most of you, you're aware, this entails reaching 90% of all persons living with HIV who will know their HIV diagnosis. 90% of them will receive antiretroviral therapy, and 90% of the latter who are on antiretroviral therapy will achieve durable viral suppression. And this is the target for 2020. So how are we doing now? A lot has been accomplished even over the past year, but much remains to be accomplished. You can see that now it's estimated that 70% of people living with HIV are aware of their diagnosis, 53% of them on treatment, and 44% of those on treatment have viral suppression. And here you can see the large gap that remains in terms of reaching the 90 targets for each of the 90 targets. This involves millions and millions of people that we must be able to reach in the next few years. The quality gap is very evident when you look at retention in care, and this slide shows from a variety of programs that at 48 weeks after initiation of treatment, the average is about 60% to 70% of people who initiated treatment are retained in care. So obviously, we need to do a lot better. Now, in terms of efficiency, there's also concern and the funding for the programming. And on this slide here in this figure, you can see that in the past decade, there's been a plateauing of development assistance for health, not just for HIV in this teal color, but also for other programs as well. So we are challenged by needing to increase coverage, increase quality, at the same time become more efficient in order to be able to reach this with a plateau in the funding. So next I come to differentiated service delivery, DSD, which I said POSIT has been proposed as a way to address some of these challenges. So the bottom line is, and this is the cover of a book that I found recently, is that what got us here won't get us there. And I'll tell you why. So what got us here thus far? We've been quite successful in the scale-up of treatment, primarily because of the attention and the commitment to the public health approach. This is very important. This allowed the scale-up. Without the public health approach, in all likelihood, we would not have been where we're at now. This involves a consistent package of care that's undifferentiated with uniform ART regimen and monitoring approach, an algorithmic approach that enables ease of training at scale, task shifting and task sharing from different clinical providers and community workers and peers, and obviously, most importantly, decentralization of services. However, we have now discovered there are some reasons why sometimes the programs are unable to achieve what they want to achieve. And this is one slide from a study that will be presented at this conference that elicited what are the reasons for stopping care. And the investigators divided them into, in yellow, structural reasons, in red, psychosocial reasons, and then in green, behavioral, individual reasons. And I'll just tell you the top 5 include work requirements, interfered with picking up medications from the clinic, transportation too difficult or expensive, felt well, didn't need to take the medicines, attending clinic risk disclosure to someone I know, and lastly, I spent too much time at the clinic. So these are the realities that many of people living with HIV today who've initiated antiretroviral therapy, these are the reasons they're telling us why they start treatment. So now comes DSD, hopefully, to the rescue. So what is DSD? It's a client-centered approach that simplifies and adapts the HIV service across the cascade and to reflect, very importantly, the preferences and expectations of various groups of people living with HIV, not as a whole homogeneous group, but various subsegments of the population, while at the same time aiming to reduce the unnecessary burdens on the health system. So the goal is not just to decrease the cost and decrease the burden on the health system, but the goal is also to meet the needs of people living with HIV and to achieve the goals of coverage and quality. What does it mean? It really means simply putting people living with HIV at the center and then designing the model of care in response to their needs. This means manipulating the service intensity, the service frequency, the service providers, and the service location. And if you look at it this way, it is about shaping the how. How are the programs shaped? How are they responsive to specific needs of subset of population? And these are the parameters that I mentioned that need to be adjusted in order to meet those specific needs. And ultimately, if we can shape the how in an appropriate way, we'll be able to achieve the 1990 targets, quality of life for people living with HIV, efficiency, equity, and ultimately epidemic control. Now, there have been several DSD models that have been successfully implemented and in some settings have actually been scaled up. And these models have largely focused on stable patients. And what do I mean by stable patients? These are patients who've received ART for at least a year. They've had no adverse reaction, no concurrent illness or pregnancy, have a good understanding of the need for lifelong adherence, and also have evidence of treatment success, either if you have viral load, 2 consecutive measurements of suppressed or undetectable viral load, or a rising CD4 cell count or high CD4 cell count with adherence, with high adherence. So the models that have been developed have been shaped by the needs of the populations, and some of them have been community-based ART groups, and some have been facility ART clubs, and many, many other models. And as I mentioned, some of these have actually been scaled in some settings. So these are some data from adherence clubs in South Africa between 2011 and 2015. And you can see on your left, yes, in this figure, that over time, this period of time, there's been a remarkable increase in the percent, this line here, in the percent of total ART cohort who are participating in an adherence club, which means less frequent visits to the clinic and more of a collective way of remaining in care. And you can see that at the same time, there is expansion in the numbers of patients on ART, but this lighter gray section are the patients who are in ART clubs. The numbers are very large, more than 32,000 patients enrolled in more than 1,300 adherence clubs at 55 facilities. Now, what have been the outcomes amongst participants in these community adherence clubs? And these are data also from South Africa that look on this side here in the A and B panels on retention, and on this side for the viral suppression. And essentially what the data show that retention is quite good, so viral suppression is quite good, and there's no difference noted between men and women. However, when you look at the lower panels, you can see in this panel here in green that retention amongst youth, those between the ages of 16 and 24, is significantly lower than amongst adults, although viral suppression remains similar. I want to, though, caution you that the numbers of youth are quite small in this group. There also has been the scale-up of community ART groups in Mozambique. They were the pioneers in expanding community ART groups. And again, the data are quite encouraging in terms of retention in care, about 90% retention at 48 weeks, as well as looking here also that some differences have been noted between urban, peri-urban, and rural areas, with inferior retention in rural areas. Another subset of individuals that are challenged in terms of retention are women after they deliver, postpartum women. And in this study in South Africa, postpartum women were given a choice. And the choice was to participate in community adherence clubs or to continue follow-up in primary care clinics. And you can see from the data that 65% chose the community ART clubs, or 35% chose the primary care clinics. And these are the top 4 reasons for making their choice. And for the adherence clubs, they cited preference to receive care outside the health facility, having fewer appointments, visits are shorter, and happy to receive the ART care from a counselor. On the other hand, there are others who prefer to be in a clinic because they wanted more intensive follow-up or lived near a clinic facility. The important thing is at 6 months postpartum, there was no significant difference in the viral load suppression between the two groups. Very importantly, I think, and this is something that all of us need to focus on more substantially, are the voices of the recipients of care and their providers. And these are qualitative data from the community ART groups in Malawi. And here's a female CAG member that says the group is good. It's like family, doing things together like a family, understanding each other. And then from a medical assistance perspective, he says, at first, I had lots of patients. Instead of taking the time to be with them, I was busy looking at how many more people were left outside. And because of these clubs, the congestion has been reduced. Now, the challenge is that while most models have focused on stable patients, there are many, many subsets of patients that also need tailored services. I think a group that's very important, often forgotten, are people living with HIV at risk for disease progression. Men, adolescents, older persons living with HIV, now with an aging cohort of people on ART. People living with HIV with comorbid conditions like tuberculosis and non-communicable diseases, migrants, mobile populations like minors, for example, and key populations. Now, let's focus first on people at high risk, persons living with HIV at high risk for disease progression. This includes 2 groups. One group are the people with advanced HIV disease at time of initiation of treatment, and then those who've been on ART but have unsuppressed viral load or low CD4 cell count or comorbidities. And this population is in need of more innovations, more ways of determining the how best to serve their needs. Now, there is good news. The median CD4 cell count at ART initiation has been rising in the countries listed below. However, importantly, the median still remains at ART initiation, remains below 350 CD4 cell count. And if we look at it in a different way, at what proportion of patients are with advanced HIV disease at ART initiation, you can see in this figure that between 30% in women to 40% of men who are starting antiretroviral therapy in low and middle income countries are starting so with CD4s less than 200. And we know that this group is at higher risk of mortality. So what is happening? Fortunately, WHO just released guidelines that are focused on managing advanced HIV disease patients. And we at ICAP have developed this call to action, seeking, again, innovations and work to try to shape some models that are responding to the needs of this population in particular. I need not tell you about the gap in men in terms of the 1990. You're all aware probably of the FIAs, or the population-based HIV impact assessments in the 3 countries, Zimbabwe and Malawi and Zambia, that were released. And the combined data here show that whether you look at awareness of status, being on ART, or being virally suppressed, men in blue have inferior outcomes to women in green. Similarly, also from the same FIA data, again, while remarkable progress has been made collectively in this pooled analysis across the 3 countries in terms of the 1990, across the age between 15 to 59, when you disaggregate the data, and this is something that Ambassador Birx actually has been advocating for, is disaggregating the data, you'll see that, again, in this younger group, their cascade remains suboptimal, particularly the first 90 awareness of status. And this means that for men or for youth, there's the need to shape these DSD models to meet the needs. There's some interesting models that have been developed. For example, the teen clubs in Malawi that show, for example, here, that retention on ART up to 6 years after ART initiation amongst these young individuals, these teens, was substantially higher in participants in the clubs versus those who did not participate in the clubs. Now, there are also challenges in terms of key populations, and these are alarming data, again, from the UNAIDS, showing that in gay men, examples, gay men in Russia, people who inject drugs in India, or in men who have sex with men in India, the cascade is really quite alarming. And this means, and we know why, that these populations we're not reaching, we're not able to reach, we're not able to retain. Somehow, and for many reasons, we've not been able to shape the services that can successfully engage and retain them in the services for a lot of reasons, including stigma, discrimination, discriminatory laws, and many, many other access impediments. And you can see on this slide, even within specific countries, these are data from Kazakhstan, Kyrgyzstan, and Tajikistan that show the continuum of treatment here, of care in Central Asia. And in red is the continuum amongst people living with HIV who inject drugs in these same countries versus the continuum of care in patients who do not inject drugs. So even within the same context, we know that this disparity is huge and needs to be addressed. And all of us, the onus is on all of us, is to remedy this situation together. Now, what about efficiency? Facility-level annual costs have been looked at per ART patients per year, and the data show that actually the majority of the costs are due to personnel costs and ARV costs. There have been attempts to try to address this with visit spacing in Zambia, and through an intervention, it has been shown that proportion of patients on three-month refills can be increased, and importantly, the average number of visits per site per day per site has also been substantially decreased, allowing for, again, unburdening of the health system and efficiencies. Also, streamlined care models have been looked at in Kenya and Uganda through an intervention, a multi-component intervention listed on this slide. And some of the gains have been remarkable. About 25% decline in the hours lost from work for people living with HIV, 30% reduction in hospitalizations, which is good for the patient and good for the healthcare system, and almost 50% reduction in healthcare expenditures. So finally, I'm going to touch a little bit on the way forward and some conclusions. So I focus this talk on the how. DSD is about the how. How can we design the programs that meet the priorities and perceptions and the needs of specific populations by manipulating these various parameters? But I do think we also have a long way to achieve the what. And only with focusing on the what as well as the how we'll be able to achieve impact. And what do I mean by the what? We do need better effective, more effective, safe, tolerable, convenient, and affordable ART options for all populations, especially for children. We do need also similarly effective, safe, and well-tolerated interventions for prevention and management of opportunistic infections and complications. We do need new research to identify effective and feasible supportive interventions for all these populations that I mentioned. And we do need to be able to establish a health system that has the skilled healthcare workers, the effective systems, and the monitoring and evaluation system to measure the outcomes. So ultimately, in order to achieve impact, which is our goal, and epidemic control, we cannot focus on one element of this remarkable, in this remarkable effort. We need to focus on coverage, reaching all who need the services, reaching them in the way they want to be reached, and engaging them in the process. We need to achieve high quality of the programs, and this means that it's high quality from our perspective as programmers or as public health practitioners or as researchers, but also from the perspective of the recipients of care themselves. We need to establish efficiency. It's good for the recipients of care, it's good for the health system. So we need to focus on all of these elements if we are to achieve our desired impact. So in conclusion, I believe that much has been accomplished in confronting the HIV epidemic, and I know you will agree with that as well. This is really a testimony to a global mobilization, a commitment by the global community, and a commitment by people in the field and by people living with HIV. But much remains to be done. Differentiated service delivery offers a promise for achieving the desired impact through enhancing coverage, enhancing quality, and enhancing efficiency. And thus, consequently, we are able to achieve the impact and epidemic control across the many subpopulations that we must reach. Now, all care models, whether they're differentiated or not, must be responsive to the perceptions and expectations of the recipients of care, and that's why people living with HIV are the top priority for programs. Now, there are many, many key research questions that remain that hopefully all of us will be engaged in working in partnership with civil society groups. What is the optimal design for DSD models for various subpopulations? It's unclear. Can streamlined DSD monitoring and evaluation systems be established that don't overwhelm the currently robust system for M&E of programs? What's the impact of DSD on the effectiveness and the quality of care for recipients of care? What's the impact on efficiency and the responsiveness of the health system? What are the costs associated with the various models, and what is their cost effectiveness? And also, how can successful DSD pilot programs be scaled up? Not every model is appropriate for scale-up, and therefore it's really important as we design and evaluate these programs, we think about whether and how they can be scaled up. And ultimately, I believe, finally, is that we need to retain the principles of the public health approach while shaping programs that respond to the unique needs of the people living with HIV. We cannot abandon the principles that have gotten us to where we're at now, the principles of algorithmic approach, the principle of task shifting and task sharing, of attention to the needs of the recipients of care. And therefore, we have to evolve our public health approach into a new model. And I'm calling this model precision public health. So let's stick with what has worked, what served us thus far, but let's make it precise and tailored so in the end we're responsive to the people we are serving. I want to quickly acknowledge my colleagues at ICAP and all of you and all other colleagues around the world for all your hard work and commitment and collaborations, the communities of people living with HIV, and finally, our funders. Thank you.
To introduce our third speaker, please welcome back Professor Chris Beyrer.
Well, it's now my pleasure to introduce the third plenary speaker of the morning, Professor Sheena McCormick, who is going to talk to us about adding the D to the ABC, putting drugs in the ABC of prevention. Sheena McCormick is a clinical epidemiologist. She's been coordinating HIV prevention trials since 1994, when she joined what has now become the Medical Research Council Clinical Trials Unit in the UK. And from the start of her career, she's worked in HIV vaccine trials across phases in Europe and in Africa. Since 1998, she's also been involved in microbicide trials, and she was the chief investigator of a large phase 3 vaginal microbicide trial that enrolled over 7,000 women in 6 research centers in southern Africa. She's been a consultant in HIV and genitourinary medicine since 1991, initially at the Royal Devon and Exeter hospitals, and since 1996 at the Chelsea and Westminster Hospital. Professor McCormick recently reported on the PROUD pre-exposure PrEP study conducted in gay men and other men who have sex with men, which showed a very high level of effectiveness for daily oral Truvada in a real-world setting in sexual health clinics in the UK. And PROUD was the first HIV prevention trial to use a randomization to immediate or deferred access in order to compare PrEP to non-PrEP, and to assess the impact on HIV risk behaviors and to determine if any of those changes would undermine efficacy. Although her primary and current focus is to ensure that PrEP becomes available to those who need it in the United Kingdom and Europe, I think that's a goal we can all embrace. She continues to work on HIV vaccine trials and maintains an interest in microbicides. She became a professor of clinical epidemiology at Imperial College in 2012 and joined University College London in 2013. And she's going to speak, as I said, about adding D to the ABC. Sheena.
Merci. Merci, Chris. Merci bien, IAS. Bonjour, tout le monde. All protocols observed. Okay, let's go. Here's the D, my conflict of interest statement. So where did we come from, where are we now, and where are we going? And I'll go as quickly as I can through where we came from. Well, this is the ABC, abstain, be faithful, condomize. These are 3 very helpful messages still as we fight the HIV epidemic. The decade of heart, Wafaa has spoken about this. It was an exciting decade. Initially, I don't think we believed it would come true necessarily, that it would last, but it really has done. And this means people can live normal lives with treatment, and importantly, we're making efforts to scale up. So the prevention revolution, I think, for me, began in 2005, and that was 11 years after I started. And I didn't have anything to do with this, but these are 3 fantastically consistent results. 60% reduction in HIV, 53% and 55% in 3 different locations with male circumcision. We should embrace these, and I think especially when you listen to what Wafaa's just said about the difficulty of finding and retaining young men generally, later on in life. This is still a really key intervention to be rolled out. And then in 2009, we had the RV144 trial report. It was conducted in Thailand, and this was the first glimpse that a vaccine might actually have effectiveness. It was only 31%, but in a later analysis looking at people who might have been at lower risk and exposed to lower levels of viral load, there was a 60% reduction. And this galvanized the vaccine field to get behind the concept of combination regimens. So then we start the era of highly effective prevention. And it did start quite modestly, although the room exploded in Vienna when Croatian Slim actually presented the results of the tenofovir vaginal gel study. They'd asked women to apply it before and after sex, and compared to placebo, it reduced HIV by 39%. People sometimes forget that it also reduced the risk of HSV2, genital herpes, by an even higher proportion, around about 50%. So in many ways, that was the first multi-purpose technology. And then that same year, towards the end in November, Bob Grant released the results of the IPREX study with a 44% reduction in gay men who'd been taking daily oral Truvada. And in the analysis that was restricted to those who were adherent to drug, it suggested a 92% biological efficacy. So that was exciting, and especially for those of us in Europe who were tackling an epidemic that was largely confined to gay and other men who have sex men. Now, there was nothing modest about Mike Cohen when he presented this in 2011 at the IAS meeting. Undetectable is uninfectious. This was a cleverly designed trial randomizing couples, discordant couples, to early treatment or treatment according to standard of care. And in the HIV infections that were matched to the index couple, the reduction of transmission was 96%. In fact, the only infection that occurred appeared to have occurred at a time when the virus was detectable, so before it had become suppressed. That was really exciting, and I just want to mention this poster at Vancouver that showed how when you translate that message into a community in Malawi, this is a very powerful incentive for testing, and it is a method and a means to shift beliefs and attitudes within communities. However, the old hands in the prevention field did take note of the fact that about a third of the transmissions in that study had come from partners outside the primary relationship. Now, 2011, that same year that Mike presented HPTN 052, was the year I call the roller coaster for PrEP, because in April of that year, FemPrep stopped the trial early. They'd been looking at Truvada in women. There was no benefit, and actually later on we learned that this was because of a low proportion with detectable drug. But I think it might have even been almost in the same session that Mike presented. We had Partners PrEP and the TDF2 study reporting in heterosexuals, serodiscordant couples, and young heterosexuals in Botswana. And here we see a very consistent result. So Partners had tested actually two regimens. They'd tested TDF on its own as well as in combination with FTC, and it was Truvada in Botswana. So very clear and positive result. But then at the very end of that year, VOICE, the very large trial that was going on investigating oral Truvada, oral TDF, and tenofovir vaginal gel, all given daily, closed two of the arms early. First of all, the daily oral TDF closed early, and then the tenofovir vaginal gel. Now, there was a signal here. And Jeannie Marazzo later presented results at R4P showing that if you restrict the analysis to women adherent to gel, there was a significant reduction for genital herpes, and then they've published the significant reduction for HIV. So that does confirm the biological effect of this gel. In spite of that roller coaster of a year, the FDA, taking the IPREX data and the Partners PrEP data primarily, actually approved the use of Truvada as PrEP. So first of all, we saw that takeoff of PrEP in the States. And you can see a kind of acceleration around about 2014. And I wonder if this was related to IPREX-Olay reporting the fact that there were no seroconversions in the population or in the person years in which there was a suggestion of 4 or more tablets a week of drug. The other thing that happened in 2014 was that both PROUD, the study we've been doing in the UK, and EPIGAY that was conducted here in France, reported that they were stopping early in order to give everybody in the control group PrEP. Now, what happened? This was an exciting session to be part of at CROI in February 2015. It was a real consolidation for gay men. So as Chris said, in PROUD, we compared PrEP to no PrEP. We created that situation by randomizing participants to get PrEP straight away or after a year. And what we found, first and foremost and most shockingly, was this very high rate of HIV in those that had no PrEP, 9% per year. So our expectation from the clinic was 1.5% or thereabouts. And our kind of thought was that we'd have a higher risk population come forward. It might be 3 or 4% like had been seen in the vaccine trials. We were not expecting 9%. It was a very high level of effectiveness, 86%. And actually the most likely explanation for the 3 infections we saw was that there was no drug at the time of exposure. And then the second trial to report in that session was Jean-Michel reporting the on-demand PrEP regimen compared to placebo. She had to use a placebo because we weren't sure this would work biologically. They also found a very high level of HIV in the placebo group, 7% per year, and a similar level of reduction, and the same explanation for the infections that they did see. So very consistent messages. PrEP works if you take it, and there are subgroups within key populations with extremely high rates of HIV, and they need PrEP now. So WHO strengthened their recommendation. They gave a strong recommendation at the end of that year, and that helped very much moving things forward in countries. I don't want to leave the where have we come from without mentioning the trial in people who inject drugs. This was tenofovir on its own compared to placebo, and it was conducted in Thailand. They saw a significant reduction, 49% reduction. It is difficult to separate, impossible, I would say, to separate out the benefit from injecting drug use and from sexual transmission. And I really want to emphasize that PrEP must not replace needle and syringe exchange, substitution programs, and management of outbreaks, such as they did in Indiana with case finding and then putting people onto treatment. These methods work, and they've been shown to work across the world. But you may still have substantial incidents in populations where the epidemic is primarily people who inject drugs, and you may still need to integrate PrEP in there. So where are we now? Well, we are gaining confidence with TDF and FTC rollout, and we are scaling up. I want to start this by reminding people about the transmission. So exposure is here at 0, and actually with the ultrasensitive assays, very soon, within days, you can detect virus in the plasma. So drug is needed in this tiny little bit here. And you can see that the drug you have before exposure is really going to give you a bang for your buck. So how to start? Well, for anal sex, we actually have the trial. We have IPEGAY, the double dose 2 to 24 hours before. FTC is there first. It's there within 4 hours as an active drug. So that plays an important role in allowing that proximity to the event in terms of the dosing. And the incidence in IPEGAY is really low. This is in the open label extension, 0.19. And I understand from Jean-Michel that they have seen very few seroconversions in the actual larger program that's rolling out in France. And there is an explanation around of an adherence issue for all of those. Now, for vaginal sex, there's no specific trial that is evaluated this, apart from obviously Caprisa with the gel. But 7 days of daily is where all of the PK experts are comfortable with. FTC may play an important role here, and the reason I say that is because not only does it get there quicker, it reaches a higher concentration than active tenofovir. So this is a very nice paper from Mackenzie Cottrell and JID, and it's showing you that 100% of the female genital tract tissues are there by 7 days. You get there much earlier in the rectal tissue, and at that stage in the female genital tract, it's probably only 65% of the population that's got the right sort of drug there and ready. So the next question is how to stop. So we've got the trial daily for 2 days after the last risk has been assessed in IPEGAY, but it's also been assessed in macaques. This is work from the CDC group, Walid and Gerardo. 2 doses, 2 hours before, where's my mouse gone? And 2 doses a day after. The only infection that they saw in a monkey was in this monkey here, and these are the levels of tenofovir. For some reason, the monkey did not absorb the drug so well. For vaginal sex, we're saying 7 days of daily after the last risk because it's got a nice symmetry, 7 days before, 7 days after. And I think that's comfortable to roll with at the moment. It may well be conservative. And this study, which was vaginal transmission, shows absolutely none when Truvada was given a day before and 2 hours later. But I would encourage you to come to this symposium and hear the experts talk about this. I know this is a controversial area, but really it's a detail. And actually what I've told you about the anal sex and the vaginal sex is fine. So coming back to gaining confidence and really building on what Wafaa said about the differentiated care, really, I'd like to persuade you that only a few people will need more frequent clinical contact because of issues to do with the drug. And that'll be populations who've got pre-existing conditions or on other treatment. And we have to, fess up. As you get older, your kidneys don't work quite so well. So if you're starting off with a baseline creatinine clearance that's a little bit low, then you might well need more frequent monitoring, particularly in that first year. But patients with HIV who are on Truvada and another drug and have HIV, which we know causes problems with the kidneys, we only see every 6 months in the UK. So really, it certainly does not need to be more frequent than that. Pre-existing bone density problems might be the other issue. There's been measurable loss of bone, but it's had no clinical consequence we can tell at the moment. But if people are young and growing or they have pre-existing conditions, then you might want to see them more frequently in clinic. And pregnant women, not because they should stop their PrEP, because actually pregnancy may be the time you're at greatest risk of catching HIV, but because you do want to reassess the risk and benefit equation. And the reason I say this is because of the extensive safety data we have in people living with HIV who are on at least one more drug as well as Truvada, and because of the large placebo-controlled safety data sets we have from trials like Partners, where there was a very high level of adherence. Adverse events were infrequent that led to interruption or discontinuation, and the changes were all reversible. I will add one caveat to that, having gone to the WHO meeting yesterday, because Croatia presented the data in adolescent girls and young women, and I think it's nearly a third who had stopped their drug reported side effects as the reason for stopping their drugs. And then finally, WHO have done a great job in looking at the safety in pregnant women. They've used the data sets from women who have been treated with tenofovir TDF for their hepatitis B. So I'd encourage you to have a look at this. There is something for everybody here in this toolkit that WHO launched yesterday. So scaling up is not hard to do. Here is the example from Australia. And I love this. Test often, treat early, stay safe. They're going to end HIV in 2020. They've set themselves an ambitious target, and I don't doubt they'll get there. They started in Mardi Gras in March 2016, and this is their graph of accrual. And they're now over 6,000, and they're still recruiting at about 80 a month. So fantastic. And here in France, the programmatic rollout has been very impressive. They've had a very good media campaign for gay men, for women, for trans women, and that's gone all over France. Paris has had the greatest uptake, and they know they need to work a bit more outside Paris, but it's great to see PrEP being taken up. And it's on the move in Kenya. And I really like this extract from this article about the launch in Kisumu. It was done by our population, and so we need to escalate this ownership of the data because the research was done there. This is what the journey to 1,060 providers trained looks like in Kenya. So it follows a very nice pattern that's familiar. The launch of guidelines, the implementers meeting, the technical working group, and then the big scale-up launch. And the Ministry of Health in Kenya really owned this. Now, in the UK, we didn't have quite the same support from our Ministry of Health, our National Health Service, but we still found a way, and that was really Will Nutland and Mark Thompson who launched Prepster Info and raised awareness of PrEP and helped with advocacy and lobbying. Greg Owen, who launched I Want PrEP Now and pointed the way to buy tablets. Simon Collins wrote the information leaflet that was commissioned by the British Association of Sexual Health and HIV. And we all came together to agree what the messages were going to be around daily and event-based dosing. And I'm pleased to say that the estimates from social media apps and online pharmacy provision suggest that at least 6,000 people in the UK are using PrEP in April 2017. So this is what the AVAC PrEP Watch map looks like, what's going on, and you can see just the scale of the activity. But I don't want to leave you with the impression that it's all done by any means. Taimur Nouri from ECDC prepared this nice map for me. He keeps updating it because, fortunately, green, dark green, which means there's a program, does keep increasing. The lighter green means there's some sort of planned demonstration project. The red, I'm afraid, means that there's nothing going on at all, and grey means that no data have been provided. And then I want to show you a map that's built also by Taimur, but with the help of Axel Smit from the European MSM Internet Survey. That was conducted in 2010. And using data from 2010, Axel was able to create the bubbles for the numbers of gay men who were reporting 5 or more condomless anal sex partners in the previous year. And we know that that is cost-effective. PrEP is highly cost-effective in that population. So if you look at those bubbles, and I flip back to this map, you see actually, unfortunately, we've got some quite big bubbles where there's red or grey going on. So we've still got a lot of work to do, for sure, in Europe. And as we're in Europe, and I know that there's so much optimism, I feel really positive that we've actually put more people on treatment than we diagnosed new infections last year. That is really encouraging, but this is so not encouraging. This is the new infections that go down from 2005 globally to 2015. Great. But this is what's happening in the WHO European region. And it's really driven by what's happening in the East, where in some settings, only 1 in 4 people who know they've got HIV actually have access to antiretrovirals. We do have to do something collectively about that. Some good news from that region. PrEP is coming to Ukraine. This is the meeting, the training meeting. The French team went over to train the Ukraine team in Kiev, who are going to start with a PrEP demonstration project. And I do hope that will help with testing. It will help in some way, but I do think it's money and access to drugs and getting them in the right place that's key for Eastern Europe. So coming to the last bit now, where are we going? And this is new modalities, new drugs, and new opportunities that are coming. So the dapivirine ring is not especially new. In fact, it was reported over a year ago, but it's 4,588 women in 4 countries, 2 trials, the SPIRE and the RING study. And this was relatively modest protection in the intent to treat, really, but a 60% reduction in women over 25. Again, this issue of adherence in younger women. Across multiple analyses, the effectiveness is clearly linked to ring use, this is what we would expect, but the results suggest that it's at least 56%, potentially more than 75% effect when used consistently. And also no drug interactions with contraception, very important when you're thinking about interventions for women. So they're now in an open label extension, both studies. HOPE is following ASPIRE, DREAM following the RING study. Both of these are enrolling actively, and IPM submitted an application to the European Medicines Agency to ask them to deliver an opinion on the value for developing countries. There are lots of presentations. I would encourage you to go to Topical Agents for PrEP, which is today, although there's something else I'm encouraging you to go to in that session in a moment. Katie Bungie in the Tuesday session, Safety and Acceptability of the Ring in Adolescents. And then Sharon is giving a presentation on dapivirine and the microbiome. And that's an area I couldn't fit into this talk, but it's an evolving area that I think is important. Do the bacteria in the vagina actually impact on the drug levels? So this is the long-acting injectables, the long-awaited long-acting injectables, being developed as treatment, but here as PrEP, cabotegravir. They're chasing a sample size of 4,500 HPTN 083. It's 3 phases to the study. There's an oral run-in. It's a double dummy with Truvada, so everybody will get a pill and an injection. But you start with the oral phase to make sure there's no issues with cabotegravir side effects, because we know once it's in, it's really in. Then the injection phase, and then an open label follow-up at the end to support the long tail of cabotegravir with open label Truvada. Rafi has an oral here in this session tomorrow, and so does Ian, who's reporting on the other long-acting injectable, rilpivirine. Discover, this is another non-inferiority, a big trial, aimed to enroll 5,000. They've actually got 5,400. And this is in gay and other men, have sex with men, transgender women, comparing TAF with FTC to TDF with FTC as PrEP. So 2 huge trials, and we recognize it's not possible to keep rolling out huge non-inferiority trials. And there is a session on Wednesday to try and address this. What are the alternative ways that we could evaluate these new agents? Because they are coming. Now, TAF does give an opportunity to become an implant, formulation technology for a mini osmotic pump implant by this company in Tarsia. They've already got that under FDA review for a diabetes product, and they've got a grant from Gates to develop it with TAF. And then Marty Markowitz is presenting on the MK851 EFDA product, Merck's product. It's a nucleoside reverse transcriptase translocation inhibitor. And this group's important, but you'll have to go to Marty's talk to find out more. That's today, co-chair's choice at 11 o'clock. So the ring opens the door and the possibility for multi-purpose technologies, particularly against HIV and pregnancy. But actually, if you do any 2 of the 3, you're a multi-purpose technology. So these are being developed by Conrad, the phase 1's complete, by IPM, their phase 1 is enrolling, and Pop Council have got an interesting ring in preclinical, which has got an anti-HIV, zinc and carrageenan, which are anti-STIs, and a contraceptive in it. So we've got no shortage of possibilities. We've got the inserts, the films. These products can be formulated like this, easier to carry around with you. We've got the tenofovir douche, the rectal douche, and there's a late breaker poster exhibition on that. And then Conrad are developing this intrauterine device that's in the preclinical stage. So tenofovir, which is a drug with marvelous pharmacological forgiveness, is pretty much being developed in all modalities, I think. Elvategravir seems to be another one that's been popular. And of course, that could be useful when the event-based dosing is taken late. It gives a more flexible dosing because it's getting integrase, which is at the end of the cycle. But what does the consumer want? Well, we know from the contraceptive field that the consumer wants choice. Not just a choice of a method, but they want the choice of the time they go to the clinic. And they really, if you can make the clinic a nice space to go to, that's great. So this is Dean Street Express. That is a nice space to go to. You check yourself in, so there's no embarrassing questions with the person. You collect your own sample, so there's no examination. You pop it in the pod. The girls like the fact they know they're not going to be examined. It pops around, and the machine is in the clinic where they process the gonorrhea and the chlamydia. You sit and wait for your blood test, and that's your interaction with a healthcare provider who's read what you've written in the iPad and has the opportunity to give you a tailored, targeted intervention if you need it. You'll get your results within 6 hours with the potential to be treated that same day or the next day if you have an infection. So I wanted to share with you data that, Gwenda Hughes and Valerie Delpech from Public Health England have shared with us at the clinic. Public Health England have a sexual health clinic activity data set, and they're able to tell us the number of tests that we're doing, which is the dotted line here. And this is when the Express opened in Q1 2014. So you see how our testing took off. In these red bars here, these are the chlamydia infections that we diagnosed, and that's on the scale here on this side. And the important thing to note is that the proportion of tests remains the same. And this suggests to me that we were not doing enough testing before. You know, although we were doing quite a lot of asymptomatic screening, we were missing a lot of infections. Interestingly, if you look at gonorrhea, this has gone down. So the same frequency of tests, and again, this is a hypothesis, but our explanation for this is that gonorrhea has a much shorter incubation period. So the partner notification and the contact tracing that you do for gonorrhea is probably much more effective in terms of controlling it in the community. But this is a great result and a great benefit of frequent screening, which we've undoubtedly been doing more, not just courtesy of Dean Street Express, but because of the PrEP we've been seeing, people were using PrEP in the clinic. That's a 24% decline. So what's happened to HIV tests? They've similarly taken off, and this is not just new testers, this is people having repeat tests. And of course you want to know what's happened to HIV. Well, we've seen a 42% decline in new cases. So we diagnosed 679 in the clinic in 2015 and 394 in 2016. So that is amazing. And what does ABCD look like at Dean Street? This is take a break, just us, condoms plus PEP, PrEP, and if you don't want any of those, total bareback, but you'll come in and be tested at least once a month. So now I have a film I want to share with you, some voices of PrEP users in the UK that Nicholas Faustil prepared.
Well, I was in a very long-term relationship, and after we separated, I kind of just was open to everything and was wanting to experiment and meet loads of different guys, and it just gets to a point where you learn enough about yourself to know that you need to take extra precautions. I mean, there's always temptation there to not do the safest things, and so that's when I was like, okay, you need to take this into your own hands, take care of yourself, and have extra security there. And that's when I started researching PrEP.
I'm a trans man, and when I started transitioning, one of the things that I found was I wanted to go into some of the men-only spaces and see what that involved. When I went, I enjoyed myself there, and gradually over time I enjoyed myself more and found that I was getting more involved. So I thought that PrEP would be a good idea to reduce my risks, because I'd had some issues with condom failures. I'd already negotiated condoms, but I had had a couple of issues and had been on PEP a couple of times. So I looked into PrEP as an extra measure.
We've been doing a whole range of things to try and educate people for PrEP and also to advocate for PrEP. So we've been out doing dozens of community events in gay bars, community centres, but we've also been asking people to educate themselves about PrEP so that then they can become peer educators. They can tell their friends, the people they have sex with, their family members about the potential for PrEP.
Women need to understand that they can actually do this for themselves. They don't have to count on the partner to put on a condom. They do not have to count on a partner to, to agree to anything. They themselves can say, I do not want to get HIV, I'm going to take PrEP.
It's not just about physical health though. Gay men, most of us can't remember a time when we weren't affected and burdened by the fear and anxiety around HIV and risks of HIV transmission, either acquiring it or passing it on. And there is the prospect with PrEP of a life and a sex life for gay men where that fear and that anxiety is a thing of the past.
HIV positive people feeling that they have to be with other HIV positive people and HIV negative people not being able to be with HIV positive people, that breaks down and it gives opportunity for a connection again.
I'm not embarrassed or ashamed, and no one should feel that way, because when you take PrEP, it just shows that you're taking your own health into your own hands. It shows a lot of responsibility.
So thank you, Nick. I want to leave you with a new ABCD. A for raising awareness of PrEP, but not just PrEP. Raise awareness that undetectable is uninfectious and the need for testing regularly. B is for not letting our behavior get in the way of this amazing opportunity to change the course of the epidemic. C, I was going to have for compassion, but I had to put for community, because they know what to do, so let them do it. And D is for just do it. So at the WHO dinner on Saturday night for the launch of the PrEP tool, we were talking about the P's, So I have a little ditty while you're looking at the names of the marvelous people who gave me slides and advice on this talk. Give the power to the people, put the pill in their palms. Or their pocket, or a pouch. Don't be a slouch. Tell the doctors to get lost, that'll drop the cost. Give the power to the people, put the pill in their palms. So faisons l'amour sans sida. Let's make love without the fear of HIV. Thank you.
We would like to thank our plenary speakers for their presentations in today's plenary session. Please welcome to the stage Owen Ryan, Executive Director of the International AIDS Society, and Deborah Waterhouse, CEO of ViV Healthcare.
Thank you. Good morning. So before we begin with this fantastic award presentation, I just want to give a quick thank you to our many delegates that are in the overflow rooms this morning. We had a technical issue as we were seating this morning and weren't able to open the second floor. I want to assure you for Tuesday and Wednesday we will have those floors open. So thank you for joining us. I know there are many of you in both of those rooms. I have a real privilege this morning to introduce two award segments that are near and dear to the heart of the International AIDS Society. They're both focused on HIV stigma and discrimination. For men who have sex with men, transgender people, people who inject drugs, and sex workers, stigma and discrimination create barriers to care and treatment that are prominent in their daily lives. Finding access to friendly health services and healthcare providers who are knowledgeable and accepting of key populations is in fact the key. If we unlock this, services become available to people we have been trying to access for years. For our first prize, the International AIDS Society is proud to partner with Positive Action Challenges, a ViV Healthcare-funded program to celebrate innovative ways to reduce stigma and discrimination. I'd like to welcome Deborah Waterhouse, CEO of ViV Healthcare, to award Challenge Prize for combating stigma and discrimination in healthcare settings. Please, Deborah.
Thank you. Thank you, Aaron. So this morning I'm very pleased to announce the outcome of an exciting initiative, an innovation prize run by Positive Action Challenges in collaboration with IAS. Positive Action Challenges is an initiative of ViV Healthcare encouraging new approaches to solve specific but common problems in HIV that limit health, opportunity and rights. We run challenge prizes connecting experts in HIV and international development communities with solvers and innovators from other fields. I want to start by thanking the IAS for their insight and input in the development of this significant challenge prize and for their ongoing support. We received well over 100 high-quality applications, but our independent judging panel identified a clear favourite to win the prize. The winning innovation combines a research-driven approach to train and sensitize healthcare providers on sexual orientation, gender identity, sexual health, and other needs faced by gay men, MSM, and transgender people. Please join me in congratulating the winning organizations who've traveled all the way from Vietnam to be here with us today. So from Lighthouse Social Enterprise, I'd like to introduce Don Tan Tong, and from G-Link, I'd like to introduce Mr. Lee Min Tan. Congratulations. So I just want to say a few words about these incredible guys. The Lighthouse Social Enterprise and G-Link Vietnam were unanimously recognized by our independent panel of judges for their exemplary approach to tackling stigma. These organizations collaborate to sensitize and train healthcare providers, local health authorities, and relevant stakeholders on who MSM and transgender people are, their sexual health needs, barriers to access, and the importance of providing adequate services to them. They also build a friendly healthcare services model which can be expanded to other areas. And they also raise awareness among MSM and transgender people on health self-protection and increase the numbers accessing health services, especially HIV-related services. So please join me in congratulating Dan Tan Tung and Lee Min Tan. Thank you.
For our second prize, I am pleased to bring our illustrious co-chair back to the podium. Ambassador Deborah Birx is Ambassador at Large and U.S. Global AIDS Coordinator, U.S. Department of State. Please, Ambassador Birx.
Thank you, and thank you to those who stayed and recognized that healthcare providers and frontline healthcare workers are critical in our progress. And thank you to the International AIDS Society and ViiV Healthcare for recognizing how important it is for people to be parts of programs. So it's really my pleasure to talk about these providers that are on the front line of their communities and understand deeply that stigma and discrimination remain the key barriers to people accessing the services that they need. They understand that we can't end this pandemic through medical interventions alone, and that together we must address those underlying issues that are preventing people from reaching health services, whether it's human rights violations, continued stigma and discrimination, and specifically violence. It is their work to create a non-stigmatizing environment. They are better able to protect the human rights of their clients and enable all persons in the communities to receive services consistent with safe access and a quality clinical and community-based care. We know that any person that is stigmatized or unable to access services due to discrimination in the community, that the health and dignity of everyone in that community is threatened. And the pandemic continues unrelenting and expands rather than contracts. Their work is critical and fundamental to how people access services in their communities. So I'd like to introduce the 3 winners and their nominees, starting first with from Indonesia, Louisa Ang, the Provincial Pharmacy Manager of the Provincial Health Office in Papua and Jayapura, and her nominator, Ares Setuan. Louisa is recognized for her dedication to ensuring that the facility's patients, many of which are people who inject drugs, are receiving the treatment they need without interruption. Our next winner, from Kenya, Sheila Change, the nurse counselor at the Minority Persons Empowerment Program, which serves MSMs and male sex workers in Thika, Kenya, and her nominator, Lendon Magare. Sheila is being recognized for her unwavering commitment to providing, importantly, confidential services to the clients that she serves. Thank you. And finally, from Botswana, Neo Munampula, social worker at the Youth Group Clinic in Gaborone, Botswana, who has been nominated by Chiza Mudana. Neo is recognized for her tireless dedication to her clients. Neo and Deza. Thank you for your dedication, and thank you to each of the nominees and to the winners for their advancing progress to controlling the pandemic, one client, one person, one community, one county, and one country at a time. As I award this, I just want to do an advertisement for those of you who want to know about the innovations and new ways to approach stigma and discrimination and addressing it in healthcare settings. Come Wednesday to Doing the Right Thing, 11 to 12:30 in room 251. Thank you, and please congratulate all of our winners once again.
The conference organisers would like to thank all the speakers and co-chairs for their participation. The plenary session is now over. We wish you all an excellent day at the IAS 2017 conference. As you leave the room, please remember to return your headsets at the door or give them to one of our volunteers. Thank you for your cooperation.